How about some basic anatomy? We have this superficial fascia and deep fascia. Why do we have two layers of fascia? What's the difference between superficial and deep fascia, other than spelling? What's that? Okay, so he says deep fascia covers muscles, superficial fascia will not do that. That's right. But anything that is functionally important, any major difference? What's that? Okay, excellent, excellent. That's the important difference between superficial and deep fascia. Superficial fascia is elastic, deep fascia is not. So that's a very big difference between these two structures. So now can you imagine that you have the skin, then you have an elastic cover, then you have an inelastic cover. So why do we need an elastic cover and then an inelastic cover for the body? Superficial fascia is elastic so that we can, stretch this fascia, we can accommodate more fat. Uh, it should be elastic so that we can accommodate fat. We can keep on accommodating fat. Okay? All that you're trying to hold here, if you try to pull this part, what is this that you're holding when you do this? I can't do that really because I have those six pack, so I can't do that. So what are you holding here when you hold that? What is that? Skin and superficial fascia. If you can hold a lot of skin here, that means you have a lot of fat in your superficial fascia. So that layer should be elastic. And that's very important, it should be elastic. We should have fat, subcutaneous fat, for a lot of reasons. We need that. Okay, so that is elastic. Then why do we have an inelastic cover? Okay, we have reason to have superficial fascia. So why do we need this deep fascia? This is all basic anatomy, right? General anatomy. Why do we need a deep fascia? To maintain the shape of your body, right? What will happen if you don't have deep fascia? Even with deep fascia, when we do this, right, you find a small bulge there, right? That's because of the muscles there. Okay, but this deep fascia will not let this muscle move out of the arm. If there is no deep fascia, what will happen? When you do some movement, what's going on there? The muscle is pulling the bone that is distal. If you imagine biceps here, biceps is pulling this bone, radius. So that is why we have this movement. And biceps can do that because biceps is in place. It's in arm. If you don't have deep fascia, what will happen? Next time you try to do this, the biceps will come out. When the biceps pops out, it cannot actively effectively pull the forearm. Do you understand what I'm saying? If there is no deep fascia, if you do a surgery, you cut deep fascia here, remove deep fascia from this point in your arm, what's going to happen later is the muscles of this part of your body cannot contract effectively and produce movements. Because when you try to do this, the muscle pops out, so it cannot pull. So the movement stops there. So deep fascia is very important to maintain the shape of your body and also to help muscles contract effectively and produce movements. So if you don't have deep fascia in your body, what will happen? If I try to do this, my biceps is going to come out. Okay? As I'm walking, you'll see all those muscles coming out everywhere from my body. Like we look like cartoons. When you do this movement, you see the muscle comes out. Okay, so deep fascia is again important to maintain the shape of your body. Okay? But there are certain parts in the body where we don't have deep fascia. Do you know any part of the body where there is no deep fascia? What's that? Scalp. We have something like that. It's not really deep fascia, but we have something like that. Now you know the functions, right? Now, do we accommodate more fat in our scalp, like it's going to come out? No. Any other part of the body where we can keep on accumulating fat? Right? This part. There is no deep fascia. If we had deep fascia here, what will happen? What's that? Not just fast. Think about the inelastic nature of deep fascia. It's not going to stretch. Okay? So if you had deep fascia here, what will happen? We will not be here today. Pregnancy will not be possible. Right? If you had deep fascia here, pregnancy will not be possible. You cannot distend your abdomen with this growing fetus. So we don't have deep fascia here for a lot of reasons. You cannot have excess food. If you want to have food, excess food you cannot have. If you want to drink a lot, you cannot do that. Okay? So it's for food, fluid, fat, fetus, feces, flatus. For the 6 Fs, these are normal, under normal circumstances. Right? If you want to take excess food, fluid, fat, fetus, feces in constipation, and flatus. Flatus is flatulence. Okay, so for all these reasons, we should not be having deep fascia here. Okay, to accommodate those things. There's another part of the body where we don't have deep fascia. Face. We don't have deep fascia in face. If we had deep fascia in face, we all will be expressionless, you know. Because there is no deep fascia, when the muscles contract, it pulls the skin in different sides. You know, you stretch things, you show your teeth, then we call this smiling. Okay? So that's happening because there's no deep fascia. If you had deep fascia here, your face will be flat, you know, there'll be no emotion, nothing. So face is another part of the body where we don't have deep fascia. So now you know the function of these two fascias. Now if you go to any part of the body, depending on what you see in that part of the body, you can say either we have fascia or not, number one. Number two, whether we have really thick deep fascia. I told you there is no deep fascia here, right, in front. What about the back? Luckily we do have deep fascia. Otherwise we'll be biconvex structures. We'll grow both sides. Okay, so we have a thick deep fascia at the back. It's only the front that we don't have it. Okay, it's not the whole abdomen, it's only the front. Okay, there were a lot of questions about the lymphatic drainage of breast. All that I told you, the different set of lymph nodes is for the skin, only for the skin. For the gland, it goes to apical nodes, or also known as the central axillary nodes. Okay, so this part, upper medial, will go to supraclavicular and retrosternal, also known as parasternal. Okay, upper lateral, where will it go? Mainly to pectoral and also partly to supraclavicular. If I ask you, you know, for example, lymph from this part will mainly go to all these lymph nodes, A, B, C, D, E, you know, pectoral, mainly pectoral, then supraclavicular. This part, both supraclavicular, retrosternal. This part, retrosternal, subphrenic. This part, subphrenic and pectoral. So that's about only the skin. There's only the skin. And I told you that the gland goes to the central axillary nodes. What do we have in retromammary space? What is retromammary space? The space between the breast and the pectoral fascia, right? So what do we have in that? I told you it is going to act as a shock absorber. That means you need, what do we need? Fluid, right? There should be some fluid to act as shock absorber. So we have some fluid in your retromammary space. And what is that fluid again? Lymph. So retromammary space is again filled with lymph. And what happens in later stages of breast cancer? The breast gets fixed to pectoralis major. And how will you diagnose that? What's that? You'll ask the patient to stand like this, okay, with the hands on the hip. And then when you do this, what is the muscle I'm using? What is this movement? Flexion. This is flexion. Flexion is bringing the arm close to the trunk. So when you do this, this is flexion. So what is the muscle used? Pectoralis major. So when you do this, if the breast moves up and down with this movement, you know the breast is fixed to the pectoralis major. So that's how you will confirm this. Okay, when you do this, if the breast moves with the muscle, with the movements of the muscle, then you know it's fixed. It can also be fixed to two more muscles. What are those muscles? Serratus anterior and external oblique. Okay, shall we start today's lecture? Okay, so we're going to do the arm and cubital fossa today. What we see here is the cross section of arm. Okay, that's the cross section of arm. The bone of arm is known as the humerus. That's the bone, humerus. You see muscles. This is anterior. This is posterior. So we see muscles in front, muscles behind. Medially, you have blood vessels and nerves. So if you take a section of arm here, you're going to find the blood vessels medially, blood vessels and nerves medially. In front and behind, we have the muscles. What are these muscles in front known as? What are these muscles known as? The group of muscles together, flexors. The muscles at the back, extensors. Before I go to the muscle, is there anything special about the skin of arm? Any difference between the skin of arm and forearm? Is there any difference between the skin of arm and forearm? The skin of arm is, it's not thicker, it's thin compared to forearm. It's thin, number one. Number two, the skin is freely movable. You can pull the skin in arm, right? You can pull the skin easily. You can lift the skin easily in arm, but not in forearm. And if you compare the presence of hair in the skin between arm and forearm, either it is absent or it is less in arm. Hair in arm is less or absent. So how is it clinically important? The skin of arm is suitable for skin grafting. If you want to graft skin, okay, you can do it from arm because the skin is hairless. It is smooth. Okay, so the skin is suitable for hair, skin grafting. I told you about superficial and deep fascia. Now you see the muscles in front and back, flexors and extensors. Which muscles are bigger, flexors or extensors? Not just in arm, anywhere in the body. Flexors are bigger than extensors. Why? Flexion is a movement against gravity. Okay, extension is with gravity. So naturally you need more power. Right? Naturally flexors will be bigger than extensors. So we have flexors in front in arm. Where do we have this? In our forearm, in our thigh. At the back, right? We flex anteriorly in our upper limb, the elbow, but the knee is flexed posteriorly. That means the flexors in the lower limb are at the back. So why is this difference? What's going on? During development, your upper limb started developing, like small buds, upper limb bud, lower limb bud. So they were here like that, in this angle. So what happened later is the upper limb turned 90 degrees laterally, the lower limb turned 90 degrees medially. You have limb buds. The upper limb bud turns 90 degrees laterally. The lower limb bud turns 90 degrees medially. So what's the total difference now? 180 degrees. Whatever is in front in upper limb will be at the back in lower limb. Whatever is medial in upper limb will be lateral in lower limb. Your thumb is lateral. Your big toe is medial. Right? So everything will be opposite in lower limb. Whatever is medial will be lateral in lower limb. Whatever is anterior in upper limb will be posterior in lower limb. Okay, so in case of lower limb, it will be the muscles at the back that will be bigger than the muscles in front because they are flexors. Okay, so we have these two groups of muscles, flexors in front, extensors behind. What separates them? This yellow line here is the deep fascia. Okay, now if you see this yellow line, the deep fascia is attached to the bone, the humerus. Again, if you look at this yellow line, even this is attached to the bone, the humerus. So what we have in our arm is these two sheets of deep fascia on either side of humerus, medial and lateral. They are between muscles. So what do we call them? Intermuscular septum. So we have a medial intermuscular septum, a lateral intermuscular septum that divides the whole upper limb into two compartments, an anterior or flexor compartment, posterior or extensor compartment. So what divides the arm into two compartments? It is the septa, the intermuscular septa. This is the medial intermuscular septum, the lateral intermuscular septum. Okay, now this is the flexor compartment. We see a muscle here. That's one muscle. We see another one here. Right? There's one more which we are not seeing in this section because this section is at a lower level. So there are three muscles in front. Three muscles in front, one at the back. What are the three muscles? Coracobrachialis, biceps, and brachialis. The one at the back is triceps. Okay, so this is what we are seeing here in a scan picture here. Again, the humerus, all those blood vessels and nerves. You can identify this muscle. The one that is close to the bone is brachialis. So that is brachialis. This is biceps. This will be the triceps. So what is this bone that we have in arm? It's known as the humerus. What type of bone is this? It's a long bone. Okay, it's a long bone. And we have these parts. We have a head. There is anatomical neck. This constriction is called anatomical neck here. This part is known as the surgical neck. Then we have a greater tubercle, lesser tubercle, intertubercular sulcus, you know all those things. You did osteology. Okay, so the lower end we have medial epicondyle, lateral epicondyle, capitulum and trochlea. Now what is important about this bone is its relationship. There are four nerves closely related to this bone. There are four nerves closely related to this bone. What are those nerves? What is this part known as? Surgical neck. At surgical neck we have the axillary nerve. The middle of the shaft we have the radial nerve. The lower and in front we have the medial nerve. We have the medial epicondyle. You know, if you flex your elbow, the most prominent structure that is medially present is the medial epicondyle. Right? Most bony, prominent bony structure that's present medially is medial epicondyle. Now extend your upper limb and try to roll the skin behind that bone. Try to roll the skin behind that bone. You should get a funny sensation. If you're not getting it, then you're not rolling the skin exactly at that point. You should get it. There's no way you won't get it. I've not seen any case where you have congenital absence of ulnar nerve. Okay, it should be there. Okay, the structure that you are palpating is the ulnar nerve. Ulnar nerve is the only nerve in the body that can be easily palpated. If you want to feel how a nerve feels, this is where you have to feel. There's no other nerve in the body that you can palpate. This is the only nerve that can be easily palpated. Okay, it's present only behind medial epicondyle, covered only by skin and fascia. So we have four nerves that are closely related to the bone. Axillary nerve at surgical neck, radial nerve, the middle of the shaft, medial nerve in front of lower end, and ulnar nerve behind the medial epicondyle. See some of you still trying. Do you get it? It's very easy to palpate this nerve. It's very easy. You'll feel a cord-like structure behind your medial epicondyle. So what's important about this relationship? Fractures of humerus. If you get a fracture of surgical neck, what nerve is likely to be injured? Axillary nerve. Okay, so somebody comes to you. He had a fall. You suspect there is a fracture because a lot of swelling and pain, and you suspect maybe the axillary nerve is injured. How will you confirm it? Good. Now, I'm coming to you with a fracture. If you ask me to do this, am I going to do this? I'm not going to do that. Right? I have enough pain already. Loss of sensation. Look for loss of sensation from the skin over deltoid. Okay, so if there is no sensation, axillary nerve is injured. That is confirmed. Okay, what is this next nerve? Fracture of shaft. Shaft is fractured. You're going to have radial nerve injury. What is the first thing that you'll see in radial nerve injury? Wrist drop. Good. Wrist drop. and there will be no sensation from the back of your forearm, and most part of the dorsum of hand. So radial nerve injury, we should see wrist drop. We should also see loss of sensation from the back of forearm and most part of the hand. Not the whole hand on the dorsum, but most part. To be precise, the lateral 3.5 fingers. Thumb, index, middle, half of ring finger. There will be no sensation. So that's radial nerve injury, that's confirmed. You have a fracture here on the lower end, in midline. What is the nerve? Median nerve. Median nerve injury. Now how will we confirm median nerve injury? Loss of sensation from lateral 3.5 fingers on this side, the palmar side. Thumb, index, middle, half of ring finger. Let's say most part of the palm. Most part of the palm, there will be no sensation. Okay? Then, if you ask the patient to do this, he will not be able to do this. What is this movement known as? Opposition. Good, this is opposition. The patient will not be able to do this. Okay? So that confirms median nerve injury. The last one, the ulnar nerve injury. Okay? Ulnar nerve, medial epicondyle. Ulnar nerve injury. Now, medial epicondyle is formed as a separate bone and then it fuses with humerus when you are about 16 years old. Till then, medial epicondyle is separate, humerus is separate, connected by only a piece of cartilage. So what happens frequently is in children when they are playing, this child tries to run away and then somebody is pulling the forearm. What might happen is the medial epicondyle gets separated from the humerus. Avulsion fracture. Okay, so what's going to happen again? Ulnar nerve injury. What do we see in ulnar nerve injury? Loss of sensation from medial 1.5 fingers. The little finger, there will be no sensation at all on both sides. This half is technically, it's very difficult. Forget about the half. I say medial 1.5. Go for little finger. The little finger, there will be no sensation at all. That confirms ulnar nerve injury. If the patient comes to you after some time, he'll also have this kind of a hand, claw hand deformity. Okay, ulnar nerve injury, we should have claw hand deformity, but it takes time, not immediately. First thing you'll see is loss of sensation from the little finger. Okay, so that is why this bone is important, because of the close relationship of, the medial epicondyle fracture. Fracture of medial epicondyle will result in ulnar nerve injury. Okay, we are seeing the muscles here, the muscles of the front of arm. There are 3 of them here. Okay, the first one that you will see when you are going to dissect after you remove skin and fascia will be this muscle, biceps brachii. If you lift this muscle, push this muscle to one side, then we should see these 2 muscles, brachialis and coracobrachialis. Coracobrachialis can be easily identified by the fact that it is pierced by a nerve. You see this nerve that's passing through coracobrachialis. So if you see any nerve passing through a muscle, the nerve is musculocutaneous nerve and the muscle is coracobrachialis. Okay? If you see a nerve passing through a muscle in this region, the nerve is musculocutaneous. In this picture, we are seeing only one nerve, musculocutaneous. But if I have the whole brachial plexus at this point, median nerve, ulnar nerve, all those nerves. So how do I differentiate musculocutaneous from the other nerves? Just look for a nerve that is passing through a muscle. Okay, so that nerve is musculocutaneous and the muscle is coracobrachialis. Now, this muscle first, biceps. Okay, it has 2 heads, that's why it's called biceps. It has 2 heads, that's why it's called biceps. It has 2 heads, 2 types of insertion. It crosses 2 joints and it has 2 action. 2 heads, 2 types of insertion. It crosses 2 joints and it has 2 actions. 2 heads. What are the 2 heads? We have a long head and short head. The one that is lateral is a long head. The one that is medial is a short head. Now you must be thinking, in this picture, this is longer than this. Then why are we calling this long head? Because there is a part of this tendon which is within shoulder joint, which we cannot see. Okay, this tendon is going to go all the way through shoulder joint to supraglenoid tubercle. So this is the long head. The one that looks short is the long head, and this is the short head. So just remember, the one that is lateral is long head, the one that is medial is short head. So two heads, two types of insertion. If you come down, you see there is a tendon. There is a tendon for biceps. There is also an aponeurosis. If you flex your elbow, okay, and then try to palpate in the middle of your elbow, right, in the middle, if you try to feel in the middle, you should feel something solid, a cord-like structure. That is a tendon of biceps. If you try to feel a little medially, a little medial to this tendon, right, if you try to catch the skin, hold the skin, you should feel a sharp bordered structure, a flat sheet with sharp border. Can you feel that? Can you feel that? Try to look for this tendon first. Try to look for the tendon first. You felt the tendon. Now you go a little medial to it. Try to hold the skin. You should be holding a sheet of connective tissue, and it has a sharp border. So what is this? The one that we felt first is the tendon. The one that we felt next is the aponeurosis. Normally, a muscle will end as a tendon or as an aponeurosis, but this muscle is special. It has both. Biceps has both. It has both the tendon and aponeurosis. So two types of insertion. It crosses two joints. It crosses your shoulder joint. It also crosses your elbow joint. Interestingly, biceps is a muscle of arm, but it is not attached to humerus. It is here, in front of your arm, but it has got no attachment with humerus. It is attached to scapula, and it is attached to radius, even though it is present in arm. Okay, so two insertions. Then two actions. What is the major action of biceps? What is the action of biceps? Flexion. Is it the main action of biceps? No. What is the main action of biceps? Supination. Okay. Can we prove this? Catch your biceps. Okay. Catch your biceps. Flex. You feel contraction. Okay. Now keep your forearm in pronation. Do this. You don't feel that contraction. Do it again. Do it supination. Feel the difference. Do it in pronation. Can you feel the difference? So that clearly proves biceps is not acting when you are doing this. When your forearm is in pronation, biceps is not acting. When I am doing flexion now, I am using only one muscle. Which muscle is this? Brachialis. Brachialis is the chief flexor of elbow joint. So next time you go to gym, okay, you think I'm going to build my biceps today. Keep doing this. You're not going to build your biceps. You should do this. Okay? I have big biceps because I know what I'm doing. Okay? If you do this, you're only going to develop your forearm muscles, not your arm. Okay, your biceps is not acting when your forearm is in pronation. It's a powerful supinator. When you're doing this, if your biceps is paralyzed, what will happen is, as we start this, forearm will go into pronation. If your biceps is paralyzed, you cannot hold your forearm in supination. So when I'm trying to do this, my forearm will go into pronation. That's what happens. When biceps is paralyzed, you cannot hold your forearm in supination, number one. Number two, you cannot flex against resistance. If I try to catch hold of your forearm and ask you to do this, you need to have a really powerful brachialis to do this. If you're going to do this against resistance. And so that's how you will examine. Ask the patient to flex his forearm against resistance. So biceps, remember, is not a very important flexor. It is a very important supinator. It is the chief supinator of forearm. You know what is supination and pronation? Pronation. Pronate means give. So pronation. Supinate is to beg. Supination, you receive. So this is supination. This is pronation. Okay, so to keep the forearm in supination, you need a very powerful biceps. Okay, so this muscle we know is the chief flexor. The brachialis is the chief flexor of the elbow joint. This muscle is a weak flexor of the shoulder joint. Coracobrachialis is a weak flexor of the shoulder joint. Biceps is normally biceps, two head. You may find three heads, still it's called biceps. It should be called triceps. Okay, there are variations. But the maximum reported is a biceps with five heads. It should be called pentaceps, but they still call it biceps. Okay, so you might find a third head for biceps. It is embryological. It is embryological. You know, the myotomes. Have you had embryology so far? Not to this. Okay, so if I start explaining that, then we will not be able to finish this. So it's embryological. It's an anomaly, but it's not an anomaly that's that would result in any loss of function or impairment of function. You will not even know it. Maybe I have three heads. I don't know. Maybe you have three heads. You will never know. You will never know. Okay, so it is not something that would result in impairment of any function. So it's not something bad to have an additional head for biceps. Okay, so this nerve here, the musculocutaneous nerve, is the one that supplies all the three muscles. Then it is going to continue as, after supplying these three muscles, what is the name of the nerve? Musculocutaneous. So it's going to supply muscles and skin. So after supplying these muscles, it will supply the skin of this area. It is going to become the lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. So if you suspect musculocutaneous nerve injury, what will you see first? Loss of sensation from the skin of the lateral part of forearm. But musculocutaneous nerve is a nerve that is well protected. Okay, yeah, but it can be injured in a dislocation of shoulder, but very rarely. Okay, so it is not due to any fracture. Musculocutaneous nerve will not be injured due to any fracture. It can be injured due to a dislocation of shoulder. Okay, so that's the musculocutaneous nerve. What is the root value? Musculocutaneous nerve. C5, C6, C7. And it's a branch of lateral cord of brachial plexus. Okay. This is what happens when you have a ruptured long tendon of biceps. Your long tendon of biceps, it is running through a groove here. What is this groove? The intertubercular sulcus, also known as bicipital groove. It goes to your shoulder joint. So every time you do this movement, what's happening? The tendon is moving in that groove, in a bony groove. Okay? So if you do this is fine, no problem. But when you do this, the tendon is getting stretched, right? When you use biceps, the tendon is relaxed here. When you use triceps, the tendon is getting stretched. Sudden extension, sudden powerful extension might result in a rupture of the long tendon of biceps. So when it ruptures, the long head will come into the middle of your arm and it will roll into a ball, resulting in something like that. Okay, so the tendon can be ruptured due to sudden violent extension, not flexion. So if you do this sudden violent extension, let's say you're doing some weights, and suddenly you do this, right? So this can result in rupture of long tendon, and the long head of biceps will roll into the middle of the arm, forming a ball-like thing, and that's what we see there. So that's the rupture of the long tendon of biceps. The muscle at the back of your arm, triceps. How many heads are there? Three. That's why it's called triceps. So what we see is long head, lateral head. Deep to lateral head is the medial head. Here, the lateral head is cut. This is the long head. The lateral head is cut. When you cut lateral head, you'll see the medial head. What is the attachment of long head of biceps? Supraglenoid tubercle. Long head of triceps, infraglenoid tubercle. You have the glenoid cavity in scapula with which the head of humerus articulates. There's a tubercle above, the tubercle below. Supraglenoid tubercle, infraglenoid tubercle. Supra is long head of biceps, infra is long head of triceps. Okay, so long head of triceps is attached to the infraglenoid tubercle. The lateral head of triceps is attached to humerus above radial groove. The medial head is attached below radial groove. What do we see here? We see a nerve and artery. What is this nerve? The radial nerve, and the artery is profunda brachiae artery. This is radial nerve and the artery is profunda brachiae artery. But what's important to remember, We know radial nerve supplies all the muscles at the back of your upper limb, right? This muscle, triceps, you see this branch? Do you see a branch here? That is coming from radial nerve when radial nerve is in axilla. The long head and lateral head, both number 1 and 2, are supplied by radial nerve when it is here, when it is in axilla. The medial head is supplied when the nerve comes here. This is clinically important. Okay? Radial nerve supplies long head and lateral head when it is in axilla. It supplies the medial head when it comes to the back of your arm. So, I told you, fracture of humerus shaft, you get injury to radial nerve, right? So let's say the bone is fractured here, radial nerve is injured. Will your triceps be paralyzed? No. Because out of 3 heads, 2 heads already got their nerve supply, and the nerve is in axilla. The nerve is coming, the injury is here. So the long head and lateral head will be fine. Any injury to radial nerve in arm, anywhere in arm or below, triceps will not be paralyzed. If you see paralysis of triceps, the injury to radial nerve is in axilla. You made a diagnosis on the spot. You don't have to do an MRI or CT or anything, to confirm your diagnosis. Flexion, extension. Okay, extension is fine. It's confirmed. Radial nerve. Where is it injured? Below axilla. If extension is lost, if there is no extension, where is the injury? It's in axilla. We'll do this again when I do the lecture, neurology of upper limb. Okay, we'll be doing this again. But at this point, remember, long head and lateral head are supplied by radial nerve when it is in axilla. Medial head is supplied when it is in arm. Where is the injury we are talking about? We're talking about injury here, right? We're talking about an injury here at this point. Where is this nerve coming from? It's coming from axilla. So both number 1 and 2 will not be paralyzed. Only number 3 will be paralyzed, which should not result in loss of extension. How will you examine a patient for triceps paralysis? What is the function of triceps? What's that? Extension. So how will I examine this patient? If you ask a patient, can you extend? I can extend. You don't need triceps for extension. It goes with gravity. Right? You don't really need triceps for this. It goes with gravity. We'll ask him to do this. Abduct the arm, flex your elbow, then extend against this. This is against gravity. Right? Extension of forearm against gravity and against resistance. If you can do this, your triceps is good. This is how you'll examine triceps. Okay? So you will abduct your shoulder to 90 degrees, flex your elbow, then ask the patient to extend the forearm against resistance and gravity. If you can't do that, then there is a problem. Maybe you have paralysis or a weakness in the muscle. Brachial artery. What is brachial artery? It's a continuation of the axillary artery. What is the extent of axillary artery? Outer border of first rib to the lower border of teres major. Axillary artery starts from outer border of first rib and ends at lower border of teres major. From lower border of teres major, you call this artery as the brachial artery. It then runs into your cubital fossa and it divides into radial and ulnar arteries at the level of neck of radius. So brachial artery is between the lower border of teres major and the level of neck of radius. So lower border of teres major to the level of neck of radius. So it's a long artery. Brachial artery. Brachium means arm. So the artery of brachium is brachial artery. What are the branches? There are many unnamed branches. Unnamed branches, when you dissect, the number is not constant, the position is not constant, and that's why they're not named. You may find 10 unnamed, 7 unnamed, 8 unnamed, they differ. There are 4 named branches. There are 4 of them which are named. Okay, you see this one here, the profunda brachial artery or the deep brachial artery. It runs through a space. What is that space? The triangular interval with radial nerve. Okay. Now, profunda brachii is a very important artery. It's a big artery. It goes around your humerus and again comes to the front. Then we have a superior ulnar collateral artery, inferior ulnar collateral artery. Superior ulnar collateral. What does this mean? It is going to run with ulnar nerve. Ulnar collateral. Okay, it goes with ulnar nerve. That's why it's called ulnar collateral. So there are two arteries which run with ulnar nerve. The one above is superior ulnar collateral. The one below is inferior ulnar collateral. Okay, so if you want to look for this artery intersection, go with ulnar nerve. It will be joined by an artery. So that is the superior ulnar collateral artery. Okay, this is one artery that's not shown in this picture. It is called the nutrient artery. It is not shown here. It should be coming from the lateral side and it should enter humerus. What is a nutrient artery? An artery which supplies a bone is known as a nutrient artery. An artery which supplies a bone is known as a nutrient artery. And that nutrient artery for humerus is a branch of brachial artery. Okay, how is nutrient artery important? It is important if you have a fracture and if you want this fracture to heal, you need blood supply. So we need this nutrient artery. In any surgery that you do in arm, you want to preserve this artery. Okay, the nutrient artery. Now, the nutrient artery, the direction of nutrient artery is also important. Embryologically, it's important. For humerus, the nutrient artery goes like this. Okay, it enters humerus like that, in that direction. How is it important? I told you during development that we had a membranous humerus first, then we had a cartilaginous humerus, now we have a bony humerus. Right? What is this type of ossification known as? Cartilaginous ossification. You know, from membrane to cartilage to bone, cartilaginous ossification. Now, you know, let's say when you are about 15, 16, or when you are very young, like 10-year-old, what's going to happen? This part of humerus is bony. This part of humerus is bony. The shaft is bony, but there is this part above and below, which is still cartilage. When you're 10-year-old, okay, upper part is bony, lower part is bony, shaft is bony, but there are two pieces of cartilage in between. You'll call this epiphysis. Upper epiphysis, lower epiphysis. The shaft is known as diaphysis. This cartilage is known as the growth cartilage or metaphysis. Okay, so this is epiphysis. This is also epiphysis, upper epiphysis, lower epiphysis. The shaft is known as diaphysis. The cartilage is known as metaphysis. So there are two of them, upper and lower metaphysis. Okay, now what's going on is your bone is growing above and below like that. Your bone is growing. It keeps pushing the cartilage above and below, and that cartilage will push the epiphysis above and below so that you keep growing vertically. And I told you, you stop growing vertically when you're about 20 to 22 years old. And that's when this cartilage disappears completely. So what happened? The diaphysis fuses with the epiphysis, so you cannot grow anymore. Okay, now the fusion of epiphysis with the diaphysis above and below occurs at different times. One of these two will fuse early, like this epiphysis, for example, will fuse with this later than this one. The lower end of humerus will fuse with the shaft first. When you're about 20 or 22, the upper epiphysis will then fuse with the shaft. So they don't fuse at the same time. So the one that fuses later, that part of the bone is known as the growing end of the bone. This is going to fuse first. This is going to fuse later. So which is growing end, upper end or lower end? Upper end is the growing end for humerus. Upper end is the growing end. It keeps growing when you're about 20, 22, till that. It keeps growing. How is this clinically important? Now, Somebody comes to you, 20, had a fall, complains of pain. You take a radiograph, you do an X-ray, you see a black line. This can be a fracture, or it can be the cartilage, because we don't see cartilage in X-ray. We see only bones. If you take a 10-year-old, do a radiograph, all long bones will be in 3 pieces. Upper end, a black line, shaft, a black line, lower end. Okay, and those 2 black lines are normal, the cartilage. If you don't know this, what are we going to think? We're going to think that this child has got a fracture above and a fracture below. That means this child has got multiple fractures. Every bone in the body is fractured. There are 2 fractures in every bone, one above and one below. So this is important. Somebody comes to me, 24, 25, I see a black line. No, that's not fracture. That's not cartilage. It should be a fracture, because you stop growing when you're 22. So to determine someone's age forensically, okay, you'll be asked to do this. Somebody claims I'm just 17, 16, but he's 20. So how do we confirm this? Do a radiograph. Look at all those lines. You still have it. They're below 20. So this is forensically important too. Okay, so we have to know which end of the bone is growing. Which end of the bone is growing in every bone, every long bone. Because I don't see this black line here. He's about 20, but I see a black line here because I know this end is still growing, this end is already fused. Only if you know this, you can make the diagnosis, whether it's a fracture or a piece of cartilage. So to do this, there is a mnemonic. The nutrient artery says, to the elbow I go, from knee I flee. What is this nutrient artery saying? To the elbow I go, from knee I flee. The direction of nutrient artery is always opposite to the growing end. The direction of nutrient artery is always opposite to the growing end. Where is this going? It's going down. So which is the growing end? The upper end. Okay. If you get when you go to lab, just look. Even though we have the plastic skeleton, you might still find something. There'll be a small hole in the bone here, and that hole will show the direction of the foramen, the artery. If the hole goes downwards, the nutrient foramen, if it looks downwards, the artery is going downwards. That means the opposite end is the growing end. So the nutrient artery says, to the elbow I go, from knee I flee. To the elbow I go, from knee I flee. To the elbow I go, right? What about radius and ulna? Upwards. So which is the growing end for radius and ulna? The lower end, right? For the humerus, the artery goes downwards. So that means the upper end is growing end. For radius and ulna, the artery is growing upwards. That means the lower end is the growing end. Is this clear? It will be the exact opposite in lower limb. From knee I flee. Okay, this is knee. So what is the direction of nutrient artery for femur? Upwards. So which is the growing end for femur? The lower end. Okay, what you have to look at is the direction of nutrient artery. Okay, the growing end is always opposite to the direction of nutrient artery. So this mnemonic will help you identify the growing end in 6 bones. So you don't have to look at every bone in the body. These are major bones, 6 long bones: humerus, radius, ulna, femur, tibia, fibula. Okay, so the direction of nutrient artery is very important because that tells you which end is growing. Okay, so you know what to expect in the radiograph. Okay, so we've seen the branches of the brachial artery. Anastomosis are on elbow joint. This is your brachial artery, which divides into radial and ulnar arteries. So what are the branches for brachial artery? Pins, P-I-N-S, pins. Profunda brachial artery, inferior ulnar collateral artery, nutrient artery, superior ulnar collateral artery. Not in that order, okay, not in that order, but if you just want to remember the 4 named branches of brachial artery, it's pins. Okay, here, this is your profunda brachial artery. It goes to the back. It divides into 2 branches. Can you see 2 branches here? One anterior, one posterior. This is your superior ulnar collateral. Inferior ulnar collateral also divides into two branches. Radial artery gives a branch that goes and joins with this. The radial recurrent artery joins with the profunda brachii. This is common interosseous artery that gives a branch that also goes and joins with the profunda brachii. Ulnar artery gives two branches, anterior and posterior ulnar recurrent arteries that joins with these two. This is just a picture with labeling. There's nothing to explain really. All that you have to know is these branches and how they join. Okay, so profunda brachii joins with radial recurrent and interosseous recurrent. Superior ulnar collateral joins with anterior and posterior ulnar recurrent. But what is important about this is if you get a block here, blood will flow through profunda brachii through this network into radial ulnar arteries and to forearm, right? If you get a block, nutrient artery. Okay, so what is important about this anastomosis is if you get a block in the middle of your brachial artery, in the middle of your arm, you will still get blood supply to your forearm through this anastomosis. So why do we have this anastomosis? Why do we have this anastomosis? Not because we are going to have blocks in future. How did we get this? Fetal life, right? Fetal life. You do that, your brachial artery is compressed. During development, the brachial artery is compressed here. So you develop a network so that your forearm can still grow. But that network is going to help your nerve if you get a gradual block, not a sudden block, due to atherosclerosis. Okay? Your brachial artery is becoming narrow, then all these arteries will enlarge to compensate. If you get a blocked nerve suddenly for some reason, it's not going to help you. Okay? A sudden block in brachial artery, the anastomosis around elbow joint will not be helpful. Okay? Now, brachial artery, where can we palpate brachial artery? Again, go to this tendon of biceps, or just extend your elbow, feel, extend. When you flex your elbow, the artery will go deep. You cannot feel it. If you want to feel brachial artery, elbow should be extended. Just touch, you can feel it, right? If you carefully observe, you can even see the skin moving. Well, if you don't have much fat in that area, you can see the skin moving. So when you extend, the artery is very superficial. So it can be easily injured. Right? Any laceration here will bleed to death because brachial artery is a big artery. It's a very big artery. So when you do extension, the artery is very superficial. Okay? So that's brachial artery. It can be palpated there. Or you can do this in the middle of your arm. Medially in the middle of your arm. Just press. Can you feel it? That is where you will compress the artery if you want to minimize bleeding. Okay, somebody comes to you with bleeding from radial artery or ulnar artery or some artery in forearm, you can compress. If you don't have a tourniquet or anything, you can just compress the artery at this point. You can minimize bleeding. So this is very important. Compression of the artery here to minimize bleeding. Okay, so these are 2 points where you can feel brachial artery. Brachial artery is used here to record blood pressure for auscultation. Clinical anatomy of the arm. We know what happens in musculocutaneous nerve injury. We know what happens in axillary radial nerve injury. Supracondylar fracture. What is supracondylar fracture? If you have a fracture of humerus here, these are the condyles, right? The epicondyles. If you have fracture of humerus here, at this point, okay, somebody had a fracture at this point, supracondylar fracture. Then you're trying to help him. Okay, but you don't know anything about anatomy, no idea. You think, okay, you don't know it's a fracture. So you think, okay, let me apply some pain balm. Do all this thing. What are you doing? This is bone that's fractured. When you do this, you're pushing something in between. There is a muscle. What is that muscle at this point? That is closely related to the bone? Brachialis. When you're doing this, you're pushing the brachialis muscle between the fractured bones. Right? Muscle goes in. Still keep doing this. You're pushing the median nerve inside. You're pushing the brachial artery inside between the fractured bones. When you are taken to the hospital and somebody there is not doing what he or she should do, they put these bones back in place, apply a cast. What happened now? You got your brachialis trapped, you got your brachial artery trapped, you got your median nerve trapped. Okay, so applying as okay, you go home, come after 3 weeks, 4 weeks. What's going to happen? You're going to come with this kind of a hand. What happened? Because the brachial artery is trapped, there is no blood going to. I told you, sudden block in brachial artery, your anastomosis around elbow will not be helpful. This is sudden block. Muscles and nerves will undergo ischemic changes after about 6 hours. 6 hours, no blood supply, there will be changes. And you're asking him to come after 3 weeks, 2 weeks, So what happened? All the muscles here are almost dead. So they become fibrous. When muscles shorten, what will happen? They become fibrous, they become short. When muscles shorten, what will happen? They'll pull the attachment. All these muscles here are attached to the fingers. They become short, they pull the attachment. So the patient comes to with this kind of a hand. And if he comes to at an early stage, if he comes to you at an early stage, now this is shortened now. Now, if you flex the wrist, if you flex, you are doing it. If you flex the wrist of the patient, the distance between your forearm and fingers is reduced, right? When you flex the wrist, the distance between the muscles of forearm, the fingers is reduced. So what will happen to the muscles now? They relax. When they relax, the fingers will straighten. Extend the wrist, the fingers will flex. Do you understand this? Do you understand what I'm saying? This is happening because the muscles have become short due to ischemia. So when you flex the wrist, the muscles will relax because the distance is reduced. The muscles now relax, so the fingers will move backwards. So passive flexion of wrist will result in extension of the fingers. Extension of wrist will result in flexion of fingers. If you see this change, there's only one condition that you'll see this change. That is a condition due to lack of blood supply. And this condition is known as Volkmann's ischemic contracture. This is the condition. Volkmann's ischemic contracture. Volkmann's ischemic contracture can happen due to a lot of reasons. There are many reasons for this. One of the reasons is entrapment of brachial artery in a supracondylar fracture. To avoid this, what should you do? Before you fix the fracture, what should we do? Look for radial ulnar pulse. If you don't find radial ulnar pulse, your brachial artery is struck somewhere. It's compressed. Okay, if you don't see that, you can't do the reduction now. You have to do an open reduction. You have to open the arm to see what's going on. Okay, if radial and ulnar pulse are fine, your artery is fine, brachial artery is fine. So it's a simple thing before you straighten up the bones. Look for this. If you don't do that, then you're going to have a patient with this condition. I told you the muscle also is trapped, right? The muscle is trapped. So when I'm doing this flexion, at some point I cannot do this because the muscle is trapped, right? I cannot do this full flexion. So there is loss or impairment of flexion at some point. So that tells you there is entrapment of brachialis. So what happens after some time is that part of the brachialis muscle that is trapped between the bones also gets ossified. You have a piece of muscle between the upper and lower end of the bones, and that piece of muscle undergoes changes, ossification changes. There will be calcification of the muscle, there will be ossification of the muscle at that point, and that condition is known as myositis ossificans of brachialis. Myositis ossificans of brachialis. So whatever changes that you see in that muscle due to this fracture, that is known as myositis ossificans of brachialis. What is the other complication? You know, median nerve injury, what will happen? Loss of sensation, but this patient is coming to you after 3 weeks. So what will happen? You know, we have these two elevations in our hand, thenar and hypothenar eminences. Thenar eminence is present only in human beings. This is present only in human beings, not in our close relatives, apes. They don't have it. So what will happen? These muscles will paralyze and your hand will now look like that of an ape. Okay? So this is called the ape hand deformity or the ape thumb deformity. Anybody with median nerve injury, this part will be flat. This will be flat and they cannot do this, right? They cannot do apposition. So you'll see this patient coming to you with that condition also if median nerve is injured. Okay? The other complication is for the bone to heal, the fracture to heal, the fractured ends should come together. But you have a muscle in between, an artery in between, a nerve in between. So the fracture is not going to heal. The fractured humerus, it's not going to unite because of all these things in between. Pronator teres syndrome. Okay, what is pronator teres syndrome? Let me show this muscle first. You see this muscle here. This muscle is called pronator teres. Okay, this is in cubital fossa. This is biceps. What is cubital fossa? This depression that we have here, a triangular depression in front of our elbow, it's called cubital fossa. Okay, the muscle that is present medially is called pronator teres. Your median nerve enters forearm between the two heads of pronator teres. It goes between two heads of pronator teres at this point. I told you median nerve is here, right? It goes into your forearm between the two heads of pronator teres. What is the action of pronator teres? Action of pronator teres. Name itself says, right? Pronation, pronator teres. Now I told you go to gym, keep doing this. The forearm is in pronation. So what are we going to develop? You're going to develop your pronator teres and other muscles. So if you keep doing this, what is going to happen? These two muscles become bigger and bigger, and then they compress the nerve, median nerve. Okay, what's going to happen? You're going to have pain from your palm. Okay, you keep doing this, one day you get pain. That tells you stop doing it. Okay, you're not doing the right thing. You think, okay, I want to definitely build my biceps today. Keep doing it, keep doing it. Your median nerve will get compressed. Okay, that will lead to paralysis of muscle supply to the median nerve. So that may lead, you think your muscles are becoming bigger, your muscles are becoming smaller here. It would look like an ape, right? Ape thumb deformity. That's what will happen. Okay, so that condition is called pronator teres syndrome. What is pronator teres syndrome? Compression of median nerve between the two heads of pronator teres. Okay, coming back to this triangular depression. So that's a triangular depression. Laterally, we have this muscle, brachioradialis. Medially, we have pronator teres, and superiorly, it's an imaginary line that connects the two epicondyles of the humerus. So cubital fossa is a triangular depression that's bounded by brachioradialis laterally, pronator teres medially, and an imaginary line. If you draw a line here connecting the two epicondyles, that forms a triangle. Again, the boundaries laterally brachioradialis, medially pronator teres, and superiorly the imaginary line. Okay, what's important about this area is that we have some blood vessels and nerves. What forms the roof of this depression? You're looking at depression. What is the roof here? Skin. What's next? Superficial fascia. But in superficial fascia here, we have an important structure. This is skin removed. Skin has been removed. Superficial fascia, we see some veins. You see a cephalic vein laterally, a basilic vein medially, joined by a median cubital vein. You should see these three veins when you do the lab. At this point, you should reflect only skin. Cephalic vein, basilic vein, joined by median cubital vein. So we have a vein that is present laterally and a vein that is present medially. If I do this, right, this border of the forearm is close to my head, cephalic vein. This border is close to the base, basilic vein. And they are connected by a vein that is called the median cubital vein. That median cubital vein is important because this is the vein that we commonly use for IV injections or infusions, whatever it is. Why not the other veins? You see these veins here? A lot of veins here. Why not these veins? If you try to pierce this vein, if you try to just touch this vein, the vein will move. These veins move, number one. Number two, try comparing the network on the dorsum of your right hand and left hand. It's not the same. Even in your own body, the right network and left network that we see here is different. The patients, hundreds of patients, thousands of patients, different size, shape, you're not going to find this vein. And even if you find a vein, you try to pierce this, the vein moves, you go puncture something else. But this vein is always present at this point. The median cubital vein is always present at this point, and it will not move. Why? Why it will not move? What is this structure here that we felt earlier? A sheet of connective tissue, bicipital aponeurosis. The median cubital vein is attached to the bicipital aponeurosis. The median cubital vein is attached to the bicipital aponeurosis. So this vein will not move. That is why we use this vein for IV injections and infusions. Okay? When you go into the triangle, you should see these three structures: contents, tendon, artery, nerve. Tendon of biceps, brachial artery, median nerve. Tendon of biceps, brachial artery, and median nerve. These are the three contents of the space. We felt all these structures earlier. What else will we see in a depression? What else should we see in a depression? Lot of fat. Any depression in the body is filled with fat to give a smooth contour to the body. So there will be a lot of fat here. That's called the cubital pad of fat. When you remove all the structures, when you remove all the contents, you're going to see two muscles forming the floor: brachialis above and supinator below. We are doing the neurology of, I already explained all those things to you, what happens when you have nerve injury, and we have a lecture, neurology of upper limb, next week. Okay, there is a change in a lecture next week. Okay, next week, next Wednesday, Dr. Martin is supposed to give this lecture, a lecture on hand. He will not be available here, so I will be doing this lecture. Shoulder and elbow joint will go here. So next Wednesday, 8 to 9 will be shoulder and elbow joint, and 9 to 10 will be neurology of upper limb. Okay, any question?